let's move to the next talk. That's by Dr. Sathya Ravilla. She is a professor of ophthalmology, pediatric ophthalmology and strabismology at SV Arvind Hospital, Tirupati. It's a pleasure to listen to her talks always. Over to you. She'll be speaking to us on simplifying approach to DRS.
Yes, thanks to AIOS and thanks to see a fairly full hall in a squint session, though I know some of you are here for the next one, so we'll try to keep it short. No financial interest to disclose, and consent has been obtained from all patients. So with regards to DUANS, we always used to talk about as Huber's classification 1, 2, 3. But now with regards to management, it's more important to look at it in terms of, is it an ESO, an EXO, or an ortho in primary? What is the amount of deviation in the primary gaze? So here we have the cutoff as 20 prisms. So less than 20 prisms, doing one muscle is sufficient. When it is more than 20, we need to go for 2 muscles. And we also have to look at the extent of adduction, abduction limitation, and the amount of globe retractions, upshoots, downshoots, and the values we get on the FDT. So as we know in DUANS, it's basically a misinnervation of the lateral rectus. So when the eye is in adduction, both the MR and LR are working together, and that is why the eye goes into a globe retraction and there are overshoots. And why we have to look into this is because we also need to understand the LR co-contraction there, because this could affect even the same 4 to 5 mm of medial rectus recession could have varied results if we don't take into account the LR co-contraction. So coming to a few case examples, be it esotropia or an exotropia, if it is less than 20 prism diopter in primary position, it is sufficient to do a single medial rectus. So in this patient, it looks like a very small angle, but significant face turn was there. And post 4 mm medial rectus recession, you can see her head posture being corrected. When there is a larger angle, it is important that a single MR is not sufficient. So here we have to go for 2 muscles, and we go for the contralateral muscle. So this is a patient with a 45 prism exotropia, right eye DUANS retraction syndrome, and you can see that this doing a single LR will not be sufficient here. So very similar to what was mentioned earlier, here we are operating on the other eye and we go for an asymmetric recession. So what we mean by creating a fixation DRS is basically this LR in the normal eye is weakened, so it needs more innervation to come into this eye to even bring it to the primary position to act against a normal MR. So DRS is innervational. So here we're playing with the nerves. So according to Herring's law, the other eye MR is going to get more innervation and the other eye LR is going to get less innervation. So what this also helps with is not just correcting the XT, but it also will prevent an LR contracture and a recurrence of XT. And this is why we also do it asymmetric. So in the DUANS eye, we cannot do too much of, already there's an abduction limitation, so we cannot do too much of LR recession here. So this is another patient on adduction. You can see she has a severe overshoot and a globe retraction. So here just weakening the LR will help for a certain amount, but not sufficiently. So in such cases, we go for what we call as the Y split. So the muscle is split, recessed at the desired thing, and then placed about 21 millimeters apart. So this helps the muscle slipping out, which is what happens when we have the overshoots. In a very large recession, we can detach it and then attach it to the periosteum, and this is done when there is no abduction because the LR is already not acting, so we can do a periosteal fixation and use the SR to help for the abduction. So this is the same patient where we did a right eye lateral rectus of recession of 9 mm and the LR was recessed in the left eye with a Y split at 7 mm. So post-operatively, you can see that the primary position has improved, and in adduction, though not fully corrected, there is better cosmesis. And what about abduction? So as mentioned, there is a limitation of abduction that happens, but cosmetically, the patient was very happy. So to improve abduction in cases where the MR is not very tight and where patient is concerned about abduction also, we can do, earlier we spoke about doing transposing both, then it was a partial VRT, and then now it was a superior rectus transposition with the MR recession. But more recently, there is a lot of hypo or torsion seen with just an SRT. So now the Nishida of just moving the belly transfer is seen, which was also described earlier. So this is a patient with an ESO DRS and face turn, and here we have done a 6 mm medial rectus recession and transposed the superior rectus to the LR. And post-operatively, you can see her head posture being corrected, and also the abduction is improved slightly. So in any squint and all the squints that I've been discussing today, be it competent, incompetent, it's very important we spend the time on the preoperative counseling to let the parents know, to let the patient know on what to expect, and always explain about a residual squint, a recurrent squint, and in certain situations, the chances of a postoperative diplopia. In cases of an ortho DRS, patient is happy, we don't want to touch it, except if they have significant overshoot, undershoot. So in all of these patients, multiple measurements, multiple discussions before we go for surgery. In bilateral duans, if there is fusion, best to avoid surgery. And when there is no fusion, we can go for surgery, but it has been said can be profound ramifications of the fixation DRS. So you can have very unpredictable outcomes, and Jampolsky has very nicely put it. The lesser the surgical indication, the greater the likelihood of postoperative complications. So in summary, in an ESO-Duan retraction syndrome, if it is unilateral, we can go for an MR recession or a SRT alone. If it is a deviation of higher thing, we need to operate on both eyes. If there is an associated co-contraction, we have to do a Y split. And in a bilateral ESO-DRS, again, rethink, and then when you operate, we can go for a bilateral MR recession with an SRT, very similar to the bilateral 6-nerve palsy case that Dr. Vivek just showed us. And in EXO-DRS, when there is no overshoot, LR recession. When there is an overshoot, we combine it with a Y split. And when there is no abduction activation and a very gross thing, we can go for a periosteal fixation. Thank you. I just want to mention we have an orthoptic CME coming up in Tirupati this month end. Thank you.
Wonderful talk, Dr. Sathya. I think you simplified it so much. Just want to add over here about the management of overshoots. With more evidence coming in and more cases that we all see, we try to subclassify them into two types, innervational and mechanical. Mechanical overshoot is, as you highlighted, that they are managed with a Y split. That's the best procedure. If it is innervational, try to see whether inferior oblique is overacting or a superior rectus is likely pathologic, then do the weakening of those. Otherwise, I think this is the most simplified approach. Dr. Rohit?
Just that sometimes long-standing hypertropia, particularly exo, because of the co-contractures give rise to a superior rectus contractures also adding to that. So, but invariably you are not sure whether it's mechanical or innervational preoperatively, so you would probably do your complete either anchoring of the lateral rectus to the periosteum or large with recession. And a residual hypertropia may require understanding, unless you can see an inferior oblique overaction preoperatively. So then maybe you have to go back and do a superior rectus. And often that may become the third muscle, so that also becomes a challenge. So.
Yeah, I just wanted to add...
can you highlight on
SRT
serum homocysteine levels in ischemic paralytic sevismus?
Yeah.
Because that lady was a very old lady and still...
Yeah.
No, that particular patient had, the other risk factors as well, diabetes, hypertension, and homocysteine. But we have seen patients where only homocysteine is a risk factor. And then most of the time that homocysteine is more than 20.
When the lady is 60 years, do you still consider elevated serum homocysteine as a risk level?
Patient can have homocysteine coexisting, like patient can have hypertension, diabetes. Apart from that,
the elevated level of homocysteine, is it still considered as a risk factor at the age of 60?
Yes.
Yes.
Is it considered?
Yeah. The only thing is that you cannot say that it is causative. Because the strong studies which happened, HOPE-2 trial which happened, did not prove the association. But there were limitations of that trial. So, unfortunately, the Indian trial which was started never got completed. So that's a different thing, but we can talk about in person.
But the younger age group, it is necessary to be...
Irrespective of age, if hyperhomocysteemia is there, we should try to treat.
And then that is a risk factor not only for, this ischemic, entire body, everywhere, they can cause. So obviously it would be always prudent to, order it and get it done. And if it is high, we should treat it.
Yeah.
However, we have seen that the younger patients with 6-nerve palsy, they do have more prevalence of having, the high serum homocysteine compared to elderly patients. Yeah, that's how they respond better.
We have 2 more talks. Let's continue them. Dr. Swarupa is here.